So the order of chapters that we are covering, or subjects that we're covering today: halitosis, ptyalism, gagging, or dysphagia and gagging, is the way it's presented in the textbook. But as I was just saying, I think this was a really dry subject, and a lot of it's kind of, and this cranial nerve does this, and this cranial nerve does this, and then they've got dental disease and blah blah blah. So Natalia's got some cases, so I think we just throw the order up in the air and have a discussion, if that's all right with everybody. That suits me.
Yeah,
perfect.
Suits me.
Amazing. All right. Do you want us to just chuck a case up?
Yes. Okay. So I'm gonna share my screen now. Then let me just go back to Zoom. Hopefully, it's interesting because it's just like very GP kind of world.
It's great.
That's perfect.
Yeah. I'm so starved of medicine cases. Give me more.
Okay. You see my screen?
Various roads to and from the domestic and
so 2 weeks ago, I saw a border collie called Atlas, 18-year-old neuter, beautiful boy. So he presented on the 4th of April because he had a drooping on one side of the face. So I'm going to show you the video. So this is the first one. It's hard to appreciate on the video. Now, this is when he got. So here. So on this part, can you see my indicator?
Yeah.
Yeah. Okay, so in this part, he had a swelling over here, and it looked like, like he had a droopy lower lip, and here where my hand is, he had a structure that was hard, really, really, really hard, and it was the size of a tennis ball, and he was just really quiet. So let me describe what I saw. So the severe firm swelling at the right retropharyngeal lymph node area. It measured approximately 5 times 5 centimeters. The lower lip was edematous. Rough nasopharynx exam with no sedation. I couldn't see anything. No pain and opening mouth, and no lacerations. Tongue was normal. No halitosis. And the other peripheral lymph nodes were actually normal and soft. The temperature was 39.8. So I did take a sample for FNA, and it was actually non-conclusive. I didn't get any clues whether it was an infection, whether there were malignant lymphocytes, or whether it was probably a salivary, a gland problem. So I sent him home with amoxicillin and meloxicam, because I guess that's what we do on the GP world. But in fairness, I did think, it's a very firm kind of big mass. It could be part of the retropharyngeal lymph node. Big masses, blah, 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 can benefit from that. And maybe necrotic on the inside and all of those things, blah, blah, blah. He came back for a recheck on the 11th of April with a massive improvement. And now the firm swelling on the retropharyngeal lymph node, if that's what it was, persist, but it was a smaller inside. And I did pull bloods again, and the albumin was just slightly low. So it was 27, and the normal range 28 to 44. So the reason why I brought this case, it's because when I was reading the chapter, I was like, right, I actually didn't think about the other potential differential diagnosis, like a problem within the salivary glands. And to be fair, I've never really seen myself a problem within a salivary gland. So I was trying to review the anatomy of the mandibular salivary glands, and then I was reading about salivary gland problems, and then I read that neoplasia of the salivary gland is quite rare in dogs. But then I was chatting to the other vets here, and they said that it's really rare for that to be lymphoma if the other peripheral lymph nodes not normal. So even though it's a pretty straightforward case, there's something to it that I am still thinking about it every day. And I was like, I don't know
what was this. Or
it could be a foreign body, of course, but it's just right on that lymph node. yeah, so I don't know if you guys want to discuss about that. So when he came for the recheck, this was him, and
Mhm.
he was way
Oh,
better.
so much better.
Yeah.
Yeah.
And it's just very, very small in there.
Mhm.
And no, I mean, it's super small, but in comparison to the other time, it was very, very small.
Yeah. And
And he was
lip
just,
position looks
he had
better, right?
Ptyalism. Sorry?
His lip position looks better, right?
Yes, completely no. Completely
Yeah.
no.
Much better.
Was his fever improved, Natalia?
Sorry, what was that?
Did his fever improve? His temperature?
Yes, his temperature went down. Yeah.
Mhm.
Everything, everything except for the firm swelling in the right retropharyngeal lymph node came almost back to normal. I would say it's probably the size, I don't know if a big grape, but it's still quite firm. So yeah, the only clinical sign that he had at home and when he came here was that swelling, and he had Ptyalism, or he was drooling, usually drooling.
Okay, so first question I have is, when you did the aspirate, when you like sprayed it on the slide, what did it look like to you? Did you just get nothing, like no cells, or was it bloody, or was it?
So it was a bit bloody. Yeah, it was a bit bloody, but I didn't necessarily see an obvious yellow exudate that I was like, oh, this is an infection, or this is thickish. Yeah, it was kind of bloody. And I do have the cytology report if you guys want to read it.
Interesting. I chuck it up.
Okay. Let me just...
It didn't look sticky. It wasn't like there wasn't like a salivary component to it, sort of thing.
Not that I can remember.
Yeah, not distinctively.
Yeah.
Because you're exactly right. Like masses in that region, there could be like lymph node, salivary, neoplastic, like any of the neoplasias in that region, or infections like little abscesses from penetrating foreign bodies, because that's the location where we get stick injuries most commonly.
Okay. So if you guys want to have a read, because probably you won't understand anything with my lovely accent. So this is the cytology report.
Okay.
Down.
Mm-hmm. It's not very helpful, is it?
Yeah.
What is interesting though?
Does it make it's lymph node versus
it's lymph node.
salivary gland?
Yeah. So the cells that you've gotten are predominantly lymphocytes, which probably means that it's come from a lymph node. It would be very weird to get an acute swelling that was predominantly lymphocytic in this kind of setting. Does that make sense? So if you had like an abscess or something like that, what sort of cells would you get as your main cell?
Neutrophils and the degenerative.
Exactly right. Yeah. And if you aspirated a lymph node that was draining an abscess, you'd get a more kind of neutrophilic sort of pattern to it typically. Not necessarily, but also it's rare for a lymph node. Like you guys have all felt the lymph nodes in a dog with a dental infection. Like what sort of scale of increase in size would you expect?
Moderate or?
Yeah, mild to moderate. You're not going to see a 5 centimeter unilateral lymph node that's infection, like a reactive node. So something's going wrong with that lymph node for sure. So okay, let's say that we're pretty sure it's a lymph node. We're suspicious that it's not a reactive node. What other differentials do we have? 8-year-old male neutered border collie. Well, he was a border
Sterile lymphadenitis.
Yeah, like
I only know that because my friend's dog got it
Yeah.
and saw Lucy Barker at Sash, and they did like CT scans and biopsies.
Yeah,
and it was on pred for a really long time. I don't think they removed the lymph node. I think it was in the same area.
Yeah,
and she's fine now, totally fine.
Was it a border collie?
No, it was the cavoodle.
Was it?
Yeah.
Um,
And I was like, get a cavoodle. Their only problems really are like a little bit of gut issues.
oh,
You know, hopefully it gets the poodle heart. And then it got some like weird autoimmune disease. Thankfully, they're both doctors. So they were like, oh, whatever. And they had insurance. They listened to me when I said get insurance. So it went well. But, yeah.
I saw Matt's mouth go with the cavoodle comment.
Yeah. I was like, it's a crossbreed. Yeah.
Matt works a lot with gastrointestinal problems, so I imagine he's seeing
Yeah.
foodle crosses.
Oh, they all have like funny guts, hey? But
oh, terrible.
yeah, I didn't think it would get some autoimmune sterile lymphadenitis thing.
So border collies are. Oh, sorry, go ahead, Jeff.
Sorry, around Gladesville, they all used to get otitis externa.
Yeah,
for sure.
Yeah.
So border collies are massively overrepresented with that sterile lymphadenitis. I don't know if that's globally, but locally, we've seen quite a few of them. I boldly said then the lymph nodes of that scale and size aren't going to be reactive, but sometimes they are, so it should still be on the list. We actually had a border collie that presented with a chain of lymph node right down the cervical chain, enlarged like this, like a combination neutrophilic lymphocytic or lymphoplasmacytic inflammation in the nodes on aspirates. Responded really well to pred, was on pred for a long time, presumptive neutrophilic sterile lymphadenitis. And finally, after about 3 months, we diagnosed the esophageal foreign body that had migrated out of the esophagus into the tissue around the esophagus.
No way.
Yeah. So never say never. And I think it's good to just have in your mind, it's probably this, and I'm going to pattern recognize a little bit, but like cast a wide net. We've still got neoplasia, we've still got salivary disease on our list. Like we could have a lymphocytic infiltrate into a salivary gland. And we've got both sterile, autoimmune, and infectious differentials still on our list for this patient. So the next challenge for this patient, Natalia, what are you doing with your treatment?
Yeah, so it's a bit tricky because I know that the pathologist suggested flow cytometry if I wanted to actually had more of an idea whether it was related to lymphoma. But then I chat to the other vets and I was like, would you go ahead with that? Or would you say, okay, let's go for biopsy, anesthetize the patient, take a chunk out of that to get a definite diagnosis? Yeah. And they said, he has improved a lot with the antibiotics. It's probably not a bad idea if he's improving, prolonging the course of the antibiotics. And then if at any point it gets worse, then we'll probably take a chunk and do a biopsy. Of course, like I am because I love internal medicine, I was like, oh, well, but I'm prolonging the antibiotic course, but I don't necessarily know if it's responding because it is an abscess or it's a foreign body or blah, blah, blah. But I would like to probably take a biopsy out of it and see exactly what I'm dealing with. Mm-hmm. But yeah, at the end of the day, I decided to prolong the antibiotic course and have a recheck right before it finishes. And if the swelling is still there, I would probably say, look, it's probably worth, either referring the patient for a CT scan before doing a biopsy, or if the owner doesn't want to go ahead with that, they don't have any insurance, then perhaps a biopsy. I don't know what you guys think.
Yeah.
When I started my residency, one of the adages they gave us was no treatment without diagnosis. Mm-hmm. The other question I would ask, do you want to, when you biopsy, do you want to sample a native disease or do you want to sample your modification of it after treatment?
That's an interesting point. So my approach to this case, and there's no right and wrong, I just want to emphasize that. But I usually sort of say to people, great, we've got a response. So that narrows down our differentials. It's not lymphoma, basically, based on a response to non-steroidals and antibiotics. That lymphoma gets worse progressively in the face of those two treatments. So we can kind of take that off the list and say that's been a valuable experiment. We probably don't need to do flow cytometry to characterize that any further, given we've kind of done that experiment. But my next challenge will be, okay, is this reactive or is it an abscess or something like that? And the next challenge is going to be withdrawing the antibiotics. So I'd give a reasonable course of antibiotics and then actually just say to the clients, if this comes back again after the antibiotics, then we're going to need to do CT scan because there's either something lurking in there or there's something underlying that caused an infection in there. And then I, as you said, I would ideally go straight to CT, and I would do it with them off antibiotics, because if there's a grass seed in the middle of a pocket of pus, it's going to be much easier to find if it's in the middle of a pocket of pus. Whereas you put them on antibiotics and it just disappears, and on CT you're like, can't see it.
The other question was that dog, does it have a travel history?
Travel history. They live in Narrabeen, but no, she just had a baby. They are pretty local. They take the dog every day to the dog park. That's it.
Because probably aren't so common around Sydney, but if they've been down the Riverina or Canberra or somewhere like that, different story.
Grass orms, did you say?
Sorry?
Did you say grass orms?
Grass seeds were
Yeah.
common.
We've had a run of them, Jeff, locally.
What was
Yeah, we've had a run of migrating grass seeds locally. We had one dog that is a PUO that we came in to consult on in a very local clinic to you, Natalia, actually. And as we were clipping its tummy, all of these draining sinuses burst open on its ventral abdomen. It had 6 grass seeds just migrating through its subcutaneous space.
Wow.
On its abdomen.
Mina in Hornsby says there's he often finds them, and it's only a little small one. No, apparently locally as the farmer's friend. Well, it should be the farmer's enemy, I would have thought. But
yeah, that's
Yeah,
we don't talk about that, but I see farmers' friends migrating too, in my own dog, embarrassingly.
Yeah, I've got this beautiful native grass all over my backyard that's got the perfect grass seeds in bodies. I find them in my coat.
Yeah.
there's
In
a
Hornsby. Yeah.
paper by Martin Coombs at COMBS from you on the subject that might be worth a read.
He's going to be quite the expert, I would imagine.
And do have to mention, when you see the picture of the wheat seed head that was pulled out of a bronchus, I did it.
Oh, cool. While we're sort of, I guess, on the topic of gagging, dysphagia, ptyalism, halitosis, let's talk about what caused ptyalism in this dog, because one of the presenting signs was ptyalism, just as far as having a bit of an approach to a ptyalism case without the kind of the other information we've got.
It could have been just the dog wasn't wanting to move its mouth normally. And then it just was a normal amount of saliva that it wasn't swallowing. And if there was some lip drooping, it may have been that the facial nerve was irritated. But just from pressure, can you get pressure pressing on the facial nerve and causing a palsy?
Definitely. That's a bit ventral. It's normally a bit higher up, but yes. So you mentioned not being able to essentially like swallow normal saliva. So that's pseudo-ptyalism. So they're not actually producing more saliva. It's just that it's going out, not in. And then I'd just like to have a little bit of a system in my mind when someone comes in with a presenting problem. Is it real excess salivation or is it pseudo excess salivation? And in this dog, given that we think there might be salivary gland disease, what other, it could probably be true ptyalism, couldn't it? Yeah.
So,
And then something else that's really cool is, okay, what causes increases in saliva production? True ptyalism.
well, phosphate poisoning could, but it would be more generalized.
Yeah, so more kind of muscarinic activation, yeah.
Now, limbic epilepsy, would that be like?
Yeah, we see that. I don't think that's reported in dogs, but definitely cats for sure.
I've seen it in a dog.
Have you?
In Wagga, it was.
Yeah, so there's definitely an epileptic disorder where dogs get hypersalivation. I'm not sure if it's limbic or not, but they get really swollen salivary glands, and they hypersalivate, or they have ptyalism, and they respond to phenobarbital. But I'm not sure where in the brain that is, but it could easily be limbic. So yeah. Another one.
Like GI disease will do it.
Yeah, exactly. So I reckon that's the most common reason we see dogs drooling, right? They come in nauseous. So what is the mechanism of that? This is a hard question. Sorry.
When you have nerves, your things in the GI tract, what are they called? Enteric neurons.
Yeah, good.
So then they will connect to where they connect, either is it the CTC or the end somewhere they connect to that. So then like that pathway.
Yes, good. So it's not just, so it's the vagal enteric plexus that typically senses like nausea happening from GI disease further down. What about local GI disease, like in the pharynx?
Like
Will that trigger drooling, Ptyalism? Anyone seen a cat with glossopharyngitis?
I think it will.
Yeah, absolutely. So that's actually not vaguely mediated. Does anybody know what nerve does sensory to the pharynx? Glossopharynx is a clue.
Glossopharyngeal.
Yeah, I think it's
Yeah, that's the one. Good. So glossopharyngeal nerve is a combination of sensory and motor. And the interesting thing about that nerve is that its nucleus is right next to the vomiting center. So if you've got overstimulation of a glossopharyngeal sensory pathways, it's just firing at this nucleus and you get overflow effect, and you can actually get true vomiting from really raunchy pharyngeal inflammation. So I've seen that quite a few times with dogs that have pharyngeal stick injuries. They're vomiting, actually true vomiting, and it's from overflow stimulation. They're also gagging because we've stimulated that gag reflex in the back of the throat, but there's also, you can sometimes see true vomiting as well. Excellent. So what other causes of ptyalism are there? Excess saliva production.
Mucoceles?
Oh, yeah, good. Excellent. So that's probably one of the differentials for this dog, and that's actually what I was fishing for. When you do an aspirate of a mucocele, what are you going to get?
Saliva.
Yeah.
Yes.
Yeah. And it can be quite inflamed, and sometimes you hit the tissue next to the pockets of saliva. But it's typically whatever fluid, if you get blood out, you squirt it on your slide and you smear it, and it's that sticky mucoid saliva. So that's definitely one of the differences for this dog. What breed is overrepresented for cervical salivary mucoceles?
Mastiffs?
Poodles. Actually, maybe mastiffs as well. I've only ever seen it in little tiny poodles.
Yeah.
And you go to look, they present with stridor and swelling, and you go to look in their throat and it looks like they've got a balloon like hanging over their larynx. It's really amazing. And then I send it to a surgeon. What else have we got? I don't think there's really anything else I wanted to cover as far as ptyalism. Have you got another case? Do you want to jump into another one?
Jeff mentioned, like, I think toxins in general. Would you sort of like cover that? Like the like you mentioned muscarinic ptyalism, but
Yeah.
we've sort of noted toxicity, toxicosis.
So if you've got a like acetylcholinesterase inhibitor style of toxin, so something that's going to increase the activity of acetylcholine, we're going to get amplification of all of our parasympathetic responses, which include, actually mechanism wise, increased parasympathetic activity will cause salivation. What else will we see concurrently?
Diarrhea.
Good.
And muscle, you get muscle fasciculation with it as well.
Acetylcholine has many locations. Yeah.
And but the other saying about organophosphate poisoning was in 2 or 3 days they're either recovered or dead.
Yes. Yeah.
It's a short-acting thing. Yeah.
And there's one other. So salivation, defecation. So salivation, urination, defecation, I should say. And there's one other.
Lacrimation.
Yes, good. So if you've got a dog with watering eyes and saliva, think, what have they got into? What toxicity could we be dealing with?
Ailbait.
Yeah. Anything anything
Carbamate.
anti-cholinesterase.
Yeah, carbamate's no, but not necessarily an aldehyde though.
Yes.
Yep.
Yeah. So why do we use atropine for carbamate toxicity?
Anti-muscarinic, isn't it?
Right.
Cholinergic.
Yeah, exactly. Yep. So you can reverse those effects on the parasympathetic, those hyperparasympathetic stimulatory effects.
I recently had a case, like literally last week. This was a 3-year-old Rottweiler, female spayed.
Yeah.
Essentially came for intracranial signs, like circling to the left, had right hemiparesis, and menace was decreased in the right. So I was like, this is a left forebrain lesion. She had such severe ptyalism that she was wet, like really soaked in this thing. So I was thinking, oh, should I give her atropine? But then because I also knew she had intracranial disease, I was like, I don't know if it'll increase because the heart rate will go up and will the ICP go up, and am I going to cause more harm? In the end, I didn't, because I didn't know what to do. I just left it. But like the amount of drool this dog had, and then she did proceed to have an MRI, and she does have a left thalamic mass.
Oh, interesting.
But the amount of ptyalism, I've never so far not come across this degree. Don't know what that is.
What the mechanism of that is?
I just attributed it to the brain tumor, but I don't know.
Yeah. What's thalamic?
Is the HPA axis mediated?
HPA axis. Tell me. Hypothalamic, pituitary.
Like if it's in the hypothalamus, would it just be vestibular, or like nausea if it's in the hypothalamus?
But then she didn't have any other, like she's
Vestibular's fine. Yeah,
not like vestibular ataxia at all.
No.
No nystagmus, no nothing.
And the vestibular nuclei are a fair bit further caudal. Like thalamus is like sitting on like 3, 4, 5 kind of thing. We could get with disease of cranial nerve 5. Was there any palsy, facial palsy?
No.
No, I'm sorry, facial cessation.
No.
Interesting. I wonder if she was herniating a little bit and putting pressure on it, the vomiting centers back there.
Yeah, that's what I was thinking. Like when you talked about the next to the CTZ, like the kind of osmosis of like triggering the effect.
There's one other thing I should say. When you've got really excessive pharyngeal inflammation, what other clinical sign that's not covered in these chapters at all, but one that we've covered recently, what other receptors are in that area?
Do you have the baroreceptors there?
I don't think so. Superficial one. Like what do you do if you get postnasal drip?
Gag.
Yeah, but that's in these chapters. So you might be
like with pharyngeal disease, you get stertor, stridor. Is that what you're?
Yes, all of those. So I'm just thinking, like, what could you be seeing? Like, if you've got a patient that presents with gagging and dysphagia, and there might be a mass there, for example, or something, what might help you localize that to the pharynx? What else do dogs do when they get an inflamed larynx?
Cough.
Yes, good. Thank you. Excellent. Who said that? It was Maya, was it? Yeah. Excellent. So that just really helps you to localize because when what we're talking about, we've sort of covered the respiratory responses to stimulation there in separate chapters, and now we're covering the gastrointestinal responses to stimulation there. but it's really nice clinically to just bring those together and say, if you've got, like I had a dog once that was presented for coughing, and I was doing a laryngeal exam on induction for CT, had a grass seed hanging out of its tonsil. Like it was just on the way in, and it had been coughing for like 2 weeks. Can you imagine? That was a good easy fix. So yes, coughing, and that dog easily could have been dysphagic or had ptyalism or been gagging, right? With something in that location. So just as far as localizing, that might help. Okay, another case, shall we?
Yes.
Yeah. Great.
No.
Natalia, do you have one?
Oh, I do, but I don't know if it's completely related. The only reason why I put it on the notes, I'm going to mention it briefly, and you tell me if it's going to be interesting or not. So when I was reading the chapter, something quite interesting was they mentioned what are the potential causes for halitosis, dysphagia, and differential diagnosis wise, they had, of course, autoimmune diseases that could cause problems, ulcerations in the mouth, like pemphigus vulgaris. So I was like, and lupus, systemic lupus. So I was like, well, I kind of have heard about that in the past, but I've never seen a patient myself with that.
Yeah.
So I read about it, about systemic lupus, and the clinical signs are quite vague, and they mention that the patients can develop hemolytic anemia, and they can have a positive Coombs test. So I saw these dogs that present, and they can also have non-erosive arthritis, and they can present with a limp or with a pain.
Yeah.
And so I saw this cavoodle. Well, I didn't see it, but one of my colleagues, because was limping, and the dog was sent home on Metacam. Then 2 weeks later, the dog came back because was panting and unsettled. And then that was my procedure day, and I took full bloods, and it was classic IMHA. And I was like pattern recognizing. I was like, this dog has IMHA, so low PCV. It was mildly jaundice. The total bilirubin was above 50. And I was like, this is intravascular IMHA. We need to take bloods for like a blood smear, a macroscopic cell and agglutination Coombs test. We ended up referring the dog because the PCV kept dropping. And yes, it does have IMHA, but all my colleagues were saying, why? Because the presentation was limping. And then when I was reading systemic lupus, I was like, what the hell? So do I have to put that in my differential diagnosis? But I don't know if it's related to this kind of topic. So I just mentioned it, and I put it on my notes, and I brought the case in, and I can read it to you guys just because the book mentioned systemic lupus as a differential cause, a differential diagnosis for halitosis, ptyalism, dysphagia, and all of that.
I reckon it's an interesting case, and I think the take home is that lupus just looks like absolutely anything. They're the IMHA cases that come in with other signs, and you're like, oh, yeah, you haven't come in for anemia. This shouldn't be an incidental finding, so it's therefore not the primary problem. It's maybe the most urgent problem, but and those ones, what tests are you going to do to help you get a diagnosis of lupus?
Antibody, anti-nuclear.
Good. Yeah.
But then you also like this criteria, because if you have multiple body systems involved, immune mediated multiple body systems involved, because you have some criteria like major criteria, minor criteria, because you don't always have to have A and A positive.
No, exactly. Yeah, it's not always positive, but it is very supportive. And if you're running testing like a Coombs test, it's a really nice add-on. So if you get an ANA, it's one of the major criteria. So it really helps you make a diagnosis.
Provided you don't start PRED already.
Yes, that's the trouble, isn't it? Sorry, Natalia, go ahead.
What is the name of the test?
ANA.
Anti-nuclear antibody.
Yeah.
And is that a blood sample, a blood test?
Yeah.
The other thing I was going to caution about diagnostic philosophy if you set up differential diagnoses, which we all do, of course, but you're limiting them to what you know. Whereas
what already exists.
if you list the problems and then investigate the problem, you're more likely to cast the net wider.
And not get lost in a rabbit warren, because I feel like we often end up investigating something that we're interested in that showed up on a blood test rather than what the patient came in for and what is actually impacting quality of life. I think bringing it back to clinical signs and broad mechanisms is a really nice way to approach a case.
Yeah, and what you're describing is called, I think it's called heuristic, which is what the police often do. They make a decision on who's guilty and then make
and then fill in the gaps. Yeah, absolutely. I do it all the time. It's a really fun way to practice, actually. It's kind of like gambling.
On the subject of lupus, I'm sorry I was a few minutes late to the meeting, but with the last patient, I just caught the photograph and I didn't hear if there's any blood taking. But with that was was it like a brownish small border collie? Was that the?
Yeah, that was the original one with the swelling in the right retropharyngeal.
Yeah. Was there depigmentation on the dog's nose or any nasal lesion on that dog?
No, actually.
And did you do bloods on it when it came in pyrexic?
Not actually when he came in pyrexic. I did the FNA because the owner had some financial constraints.
Yeah.
I was like, okay, bloods or FNA. And so I did the FNA first. And then when the dog came back for the recheck, the swelling was better. And then I did the bloods after, during the antibiotic course. Yeah.
Okay.
Right.
Yeah, just curious because I saw a dog that had they thought it had T cell they thought it had T cell lymphoma, but it had a nasal lesion. And I was wondering, like in that kind of color border collie, like in my head, I'm thinking like autoimmune conditions. I don't know if what other people think when they see those kind of border collies.
Yeah, we definitely talked about the sterile lymphadenitis.
Yeah, I caught that.
Yeah. And I think probably the other thing we should mention is that lymphoma is massively overrepresented in local border collies genetically. So lymphoma, like, whilst very, like we said, it shouldn't have responded to the therapy that's been given. But
unless it was epitheliotropic with a lymph node nodal extension. Because that's what, like, I saw one that the lymph node was kind of getting better, but it turned out that this dog had a lip lesion, and it ended up being epitheliotropic because they're like, oh, it's a grade, like, awesome. We found, like, this is the oncology. We found like a stage 1 T cell lymphoma, like localized to one lesion, and then I was like, but what's on its nose or on its lip or something? I just, when I saw the color of that dog, that kind of like diluted brown border collie, I thought, I'm just curious to see what was on its nose, and also curious if you got a CRP and bloods on it to see what it looked like there. But
it didn't have a raging neutrophilia at all. The only abnormality was a hypoalbuminemia, which is interesting. But
on the follow-up bloods. Yeah.
Follow-up bloods, yeah. So we may have had a neutrophilia or elevated CRP originally, but
not so much for this case. But then isn't there also like lymphoma, like you have your multicentric, but then you also have the T cell indolent lymphoma, which is so bloody slow growing that you don't even need therapy for 2 years and they're still fine.
Yeah, exactly.
So was that, do you normally, can you only get it at one node? Is that?
It's usually one node. Yeah. So I think our differentials, if this is a lymphoma, our differentials are going to be, like Matt said, extension from an epitheliotropic or something we haven't found yet.
Yeah.
Going to be very low grade multicentric B cell lymphoma, which would be like the grade 1, stage 1, where it's only one node, or it's going to be an indolent T cell one, which removal of the node would be curative, because we just haven't got extension anywhere else, which is very atypical of the type that border collies get is multicentric B cell, and it's aggressive.
Would you expect to see any clue on the FNA though, or not necessarily?
Yeah. Oh, if it's lympho?
Yeah, if it's like the indolent T cell or.
If it's negative, you wouldn't rule it out.
No. So the trick with this T cell one is it's so low grade that it comes up quite slowly. It doesn't cause a whole heap of inflammation, and you've still got all the other normal lymphocytes functioning in that lymph node. So you do your aspirate, and a lot of the lymphocytes that are there are normal. And because it's not high grade, it's not large cell, there's not just one population of lymphocytes, and all those criteria the pathologists use to say lympho versus reactive aren't there in the low grade lymphos. So the only way you can diagnose it is by biopsy.
We have a 2-year-old T cell, like multicentric T cell lymphoma in a border collie that's this kind of brown dilution color at the moment. 2-year-old germline T cell. It seems like it's a germline, genetic cause.
Yeah, right.
I would think that it's also more common in blue cattle dogs too. I've seen large around here and heard about them. I think there's a paper in the OBJ out of Sydney Uni that mentioned lymphoma in working breeds.
Oh, right.
A while back. I'm a bit vague on it because your memory goes as you get older.
I think there must be so many pockets of breeding, like Wagga local bred working dogs. There's going to be different genetic predispositions to like what's reported in most of the papers from America and stuff.
Of course, they're not a common thing now, blue cattle dogs, but the ones I saw weren't in Wagga. They were Reviston, Hornsby, and our own dog was another, St. Ives.
Cattle dogs are going to be the next big thing. Can I just throw it out there? It's because of Bluey. All the kids are going to want cattle dogs.
Stock up on muzzles.
Exactly.
Yeah, absolutely.
Oh, yeah.
Breeders.
My sister-in-law is like no back fences, like really kind of like just sort of casual human, like not big on discipline. She's like, but thinking about getting a cattle dog, and I was like, no.
Oh my gosh.
The more vicious ones.
Yeah. So she, with a 3-year-old. Well, anyway, sorry, we digress quite far from this page. So if we're talking about halitosis caused by ulcerative like oral disease, Bron's logged off. Bron actually had the smelliest mouth I've ever seen. Sorry?
I think she just lost her video.
Oh, right.
Bron had the smelliest mouth. You mean Bron had a case?
Not Bron.
Oh gosh, that dog with the
was it a chocolate Labrador? I think it was a chocolate Labrador. I had like this awful, like all its gingiva had just fallen off. It was just, and like right down to the bone, right? You could see.
Yeah, it was osteonecrosis of the maxilla and mandible.
Oh.
It was this really small black lab.
Yeah.
Who also had really severe inflammatory bowel disease, and she's the one who had that weird post surgery.
Right.
So she's got a weird circular loop that goes nowhere in her bowel. From what we can tell from ultrasound, she was referred for surgery, but because she and being looked after by Sophia at Sash, because she clinically improved, we never ended up going to surgery to fix this. What we're pretty sure is a blind loop of bowel that keeps recirculating. But yeah, she's been managed with a hypoallergenic diet for her bowel signs, and her mouth signs haven't recurred, but she needed some serious debridement of her alveolar bone with a dental specialist. Yeah. But that was halitosis.
That was like halitosis you could smell across the room. It was so foul.
Is that what the owner presented for, Bron? Like, did they present complaining about smelly breath?
So, yeah.
It's quite acute onset from memory. Like
it was. Yeah.
In humans, because I'm not sure, but Crohn's in humans can show up in various mucosal membranes, right? So I think that was like a IBD mediated
ulceration
presentation.
It's pretty sad that she has this weird disease on top of her pre-existing severe bowel disease.
Is she on pred for the mouth?
No, because we were worried that the pred that she was on for her bowel, because they put off.
That's right, she was already on it.
Definitive treatment, definitive investigation for her bowel. She's already on a lot of pred, so we're really carefully managing her atopy with topical steroids, but never giving her oral pred now. So her mouth resolved with antibiotics and surgery, debridement, but not pred.
Yeah. Sorry, Brian. And the cause of the osteonecrosis was severe dental disease?
No. She had a healthy mouth. The dental disease was secondary to the necrosis, which, because it involves so much bone, we got pathology. It was a bone necrosis with secondary tooth loss and gingivitis. I don't think the gingivitis extended to the bone, but it could be the other way around. I don't know what you think, Anna.
Well, I don't know. The fact that she's already on pred. So the two main differentials is this an invasive infectious process? Like we see this with aspergillosis and stuff. The immunocompromised patients on pred more susceptible to infectious causes. It would be very unusual to get an autoimmune, which is the main other differential disease, occurring with that degree of aggressiveness already on prednisolone.
Yeah.
And like an acuteness kind of thing. So I would say infection would be most likely. I'm interested to see whether they cultured, like fungal cultures are so hard because they take so long and the fungi die and they're all sensitive. But to see whether there was any aspergillosis component to that, because that's definitely reported.
Yeah, definitely not on the histo, but I don't think there were cultures taken.
No. Interesting.
They call it in humans. It's called in oral Crohn's. It's orofacial granulomatosis.
Wow.
And that's is it like it's a bone process that
just membranes.
Not on my quick cursory Google search.
That'd be epithelial. I would
say so. It's more stomatitis, I think.
Yeah, because this dog didn't have stomatitis. It seemed to be, and I quite like dentistry. I've never seen you get bad bone infection from periodontal disease.
Yeah.
You get tooth loss, but she had like major lysis.
And it was like the bone, the gingiva fell off the bone because the bone was so infected.
It was out of there. Yeah. And did it have any turbinate damage, like from an aspergillosis perspective on CT or anything?
It was quite localized, wasn't it? Like down the bottom.
Yeah, there was some filler, I think, on one side.
Yeah.
But it wasn't just mandible, and it wasn't.
It was symmetrical.
Not well. Both sides were affected, but not symmetrically. Yeah, it was bilateral.
Yeah.
Yeah, she's a cool case. Should dig her up.
Yeah.
She's well. I mean, dig up.
Yeah. It's not literally. So the definitely, I mean, halitosis I think is probably a pretty easy one that you guys deal with more often than I do. But the main reason I see dogs for halitosis is actually either nasal disease or GI disease further down. So I think it's important just to have in your mind with halitosis, it may be extra oral in cause. So what other extra oral diseases might cause some halitosis?
Diabetes.
Liver failure. Yeah.
Respiratory disease.
Yeah.
Yeah, good. Particularly pneumonia. If there's anaerobes involved, it's stinky. Yeah.
And diabetes, if they have the ketoacidotic diabetes complication.
Yeah.
Gastritis.
Gastritis, exactly. Particularly with hemorrhage, it stinks. Got a really distinctive smell, like really metallic, irony sort of smell. Good. Excellent. Now, the only other thing I want you to have in your mind for a patient that presents to you with dysphagia is the different phases of dysphagia. So if you've got a client, because the clients find it hard to describe stuff like this, I can't emphasize enough how important it is to watch the dog eat yourself. Don't rely on the owner's description. Make a video watching the dog eat so you can slow it down and like speed it up and see how their tongue's moving and stuff like that. Get someone on every angle with their videos and try them on different consistency foods to see whether there's any abnormalities. So can anyone tell me what the phases of dysphagia or phases of swallowing are?
Oral preparatory is one.
Yes. Yeah.
Pharyngeal, esophageal. It
Great.
goes to pharynx and esophagus.
Exactly right. So it's a pretty complicated, detailed process, swallowing, that relies on a very conscious start or very kind of deliberate start, followed by an automatic finish kind of thing. That there's definitely better words for that, but they're the ones I'm using today. So the oral phase, the oral preparatory phase, what's happening in an animal's mouth from the moment they pick up a piece of food to get it to the automatic pharyngeal phase?
Well, the tongue would be actively shifting it backwards.
Absolutely. So which nerve has to be functional to be able to move your tongue?
Hypoglossal.
Good. Excellent. Which only has a motor component, no sensory component. So what nerve provides sensory input from the mouth? There's a few, actually.
I think rostral is different. Rostral is different, and like rostral is glossopharyngeal, is it? Sensory?
It depends if taste or I think glossopharyngeal is further back.
Right, okay.
Very tip of the tongue is actually facial.
Accessory.
Okay.
Oh God, is it?
I think accessory does something, or is it goes to the okay.
I probably don't know this well enough to quiz you guys. The trigeminal is a big one. So facial sensation, inside of the mouth sensation as well. So to ball up a food bolus, move it with your tongue and cheeks to the back of the mouth in a coordinated effort at the same time as salivating sufficiently to move it to the back of your mouth. There's a lot of things going on. There's a lot of nerves involved. So hypoglossal for sure. We've got glossopharyngeal, sensory and motor. We've got vagal input. We've got facial as well from the tip of the tongue. And obviously motor function.
Accessory does not. It does the neck, sorry. So don't get confused anybody. It's not accessory.
Yeah. So yes, this like prehension is a very neurologically heavy process. So if we successfully move the food bolus to the pharynx, what happens then? The pharyngeal phase.
Isn't there is there something like physical cricopharyngeal, because you have some like, is it a sphincter or
With the upper
muscle sort of like, it's not actually a physical thing, but it's like that muscle is thickened or something.
Which has got, it's just got tone at the top.
Yeah, yeah.
Yes, yeah, exactly right. So we need to now switch from a conscious process, and as soon as the food hits the back of the throat, it moves to an automatic process. So we're going to get contraction of the tongue against the pharynx, the base of the tongue against the pharynx, which is going to move the food through that upper esophageal sphincter. That sphincter is going to relax, and then we're going to move into the esophageal phase. So if we kind of divide dysphagia into 3 phases, oral, pharyngeal, or esophageal, and then we divide each of those phases into mechanical or functional abnormalities, it's a nice way to think about it. So we've sort of talked about the functional abnormalities as far as most of them being neurological in prehension. What about in that pharyngeal phase of swallowing? What functional abnormalities do we see?
I've seen like swollen tongue bases, like
Good.
edema at the tongue base.
Edema, so acute abnormalities of tongue, yeah.
Or like lingual, lymphoid tissue swelling.
So that's more a mechanical dysfunction.
Just hypomotility, like it's not like any sort of muscle myositis sort of a thing.
Absolutely. So myositis, like myopathy,
neuropathy, myopathy.
Yeah, exactly. And we're going to have probably those same differentials for the esophageal phase as well. But it's going to present more distinctively, like the megaesophagus presentation is a little bit more distinctive.
Like the mechanical and functional, like can they interlap as well? Because I thought it was a bit confusing to like separate them that way.
So I just sort of think of mechanical as a physical barrier, whereas functional is like there's like the movements are not in the right order to facilitate the process kind of thing. Does that make sense?
Yeah.
So what other differentials are there for the pharyngeal phase? So the main other functional one I want to mention is cricopharyngeal achalasia. Have you heard of that? Kind of like urethral dyssynergia of the swallowing world. It's like the tongue moving the food bolus there doesn't result in synchronous dilation of the esophageal sphincter. It results in contraction of the esophageal sphincter. And what happens when that contracts? And there's food sitting in the pharynx larynx area.
It won't go in.
It won't go in. Where's it going to go? What's your body's response to food sitting in your larynx?
Back out.
Yeah, exactly. Yeah. So it's going to result in gagging. So this is where dysphagia and gagging are kind of a bit of a overlap. And we also see retching as a continuation of that process as well. So important, if you've got a patient presenting with dysphagia, gagging, and retching, it's probably going to be in one of those automatic parts rather than in that first oral phase.
So are gagging and retchings, are they interchangeable or not really?
No, I'm going to say no. So gagging doesn't have any gastric component, retching does.
Okay.
So I'm going to try and explain this without making vomiting noises. So my instinct is just a demo, which is just too gross for everyone. But gagging, like you've all kind of had a corn chip go down the wrong way and you go, oh. And then it's often followed by an expectoration reflex. There's air moving, whereas a retch is gastrointestinal movement. So it's coming from the gastrointestinal tract. So usually esophagus. It's non-productive by definition. So it's not a vomit, but there is stomach mixing that goes along with retching. So you get an abdominal contraction associated with it.
Okay. Thank you.
Yeah.
Because in Spanish, we don't have gagging and retching. So I was thinking the same, but I wasn't brave enough to ask.
So it's more, I think it's the air. So a gag is usually followed by a cough. So it's more localized to upper, whereas a retch just has that gastrointestinal follow through without the follow through.
Will gag always be followed by a cough? So is that one of the ways to differentiate or not necessarily?
We gag always before we cough. Oh, what was the question? Sorry.
Will gag always be followed by a cough? Like, is that enough to differentiate or not really?
Not always. I shouldn't say that. Gag just involves air movement.
Okay.
Rather than,
It's so hard to tease this out with owners. Like, was it gagging? Was it retching? Because how do you like tease it out? If they're not the same thing, then
videos.
It's hard to tease out.
Gotta be videos, yeah.
Unless you don't have video there.
Yeah, and then the other thing is gag is always like when there's something triggering that back of the throat. You might not know what it is yet, but there's something in there. Whereas retching can be like because of a bad smell and stuff. Like they can retch without, or because of megaesophagus, that's like there's nothing. It's not like they've just swallowed something or anything.
Mm-hmm.
We actually better wrap up for the day, so I don't keep you guys over time. Thank you so much for bringing cases. I loved that. That was way more fun than just going through a textbook chapter. Please do bring cases if anybody's seeing anything interesting. And
that was a great case, Natalia.
Yeah, really good. And next one is regurgitation, vomiting, and might be diarrhea as well. So we'll cover some ground, and I'm sure you've got cases to talk about. Excellent. All right. Nice to see you, everybody.
Thank you.
Thank you, everyone.
Thanks.
Bye.